Tēnā koutou katoa to the rest of you. I note that only actually 4 of us had to turn up to this meeting at this one, and so the other 3 speakers, thank you for coming, not moving out from mine. You're welcome to go. And to the rest of you who've actually stayed for my talk, I'm greatly honoured. So I want to say thank you to a few people. First of all, I'd like to say thank you to the Royal Society of New Zealand. It's a huge honour, and I think I speak for the other speakers this morning. It's a huge honour to be elected to this society, and I look forward to contributing in the years ahead as I can. There's only a small group of surgeons who have been honoured this way in the past, and at least 2 of them have been Knights of the Realm. I'm quite a long way from there. There are a couple of ophthalmologists as well, but we don't really count them as surgeons. So, now did you guys need to say something, or do I just get on with it?
Well, you're not going to get anywhere yet.
Oh, okay. The second group of people I'd like to say thank you to my university and hospital colleagues at Middlemore Hospital and the University of Auckland. I've had wonderful support over the years I've been in Auckland. We came back from overseas in 2002 and been wonderfully supported by my colleagues at Middlemore, which, to be fair, hasn't been noted as being an academic powerhouse. The University of Auckland has, but not Middlemore Hospital, and it's been wonderful to have that support and start to build something there. And third, I'd like to pay a special thank you to my whānau who are here today, my wife Laurie, beautiful woman in the back row. I know there are a number of beautiful women in the back row, but the most beautiful one to me. And my son Caleb, who's along the end there, his girlfriend Eden, who's going to come to see that I'm not quite the half-wit that I appear to be most of the time. And then my cousin and his wife Stephen Robertson and his wife Robin, who've come up from Dunedin especially for today. And Stephen's a fellow of the Academy. His wife probably should be, but she's the hard work in the family. So today, when we get this up, I'm going to talk about keyhole colectomy, which is a little departure from the normal kind of things that we talk about here today. I can almost do the talk without slides, but it does get a little difficult. Some of the concepts are a little complicated. Thank you very much. So in 1990, the principles of keyhole surgery were transferred from the gallbladder, which had been something that people had become very popular, to doing keyhole colectomy, and the first ones were done, as you would expect, in America. But it took quite a long time to accept that this was what people described as a game changer. So it wasn't until 2004 that the first real randomised controlled trials, typical of surgeons, we do things and then do a randomised controlled trial to prove something, or actually, and sometimes we show that we were wrong, but we still carry on doing it. It's the way we act. Evidence-based medicine is a little foreign concept to us. But so in 2004, the first randomised controlled trial was done, and it showed a little bit of an improvement in outcomes after that compared to what we call open surgery, which is the surgery on the left, see the great big cut down the middle there, versus the smaller incisions on the abdomen for somebody who's had a keyhole or a laparoscopic operation. And I call this, and this produced what I call a natural kind of experiment. So I think when COVID came along last year, while it was a terrible thing, there were a whole bunch of people that had wonderful opportunities for natural experiments. So the infectious disease people suddenly appeared. People like Michael Baker, who none of us had ever heard of before, unless you lived in a small part of Wellington, suddenly became national figures. And nothing wrong with that. But the point was these natural experiments are there to be taken, and we all have these. So when we had the Whakaari White Island eruption, a lot of people became experts on smoke inhalation and the management of volcanic burns, which really nobody had known much about before. So natural experiments are something that scientists in my part of scientists of all types take advantage of, and this was one of them. So this was described as a game changer. You got these smaller wounds, and at that time the recovery from surgery was thought very much to be related to the size of the wound you made in the tummy. So you did an appendectomy, obviously you got better quicker than if you had a big cut down the middle of your tummy. There was a fair amount of anecdotal evidence, a little bit of science around making the cut from a gallbladder, from a big cut across here, down to little holes, so-called laparoscopic cholecystectomy, not colectomy, cholecystectomy. And so everybody thought this was going to be a real game changer. Problem was, this is a study we did, and there's been at least 2 others have looked at this. This will look at fatigue or recovery. SRS is the surgical recovery score, not the Surgical Research Society, which is something we do have. And you can see here those lines of open surgery, which is the big cut, versus keyhole surgery. This is for taking out bits of colon, almost exactly superimposed for the first month or so, first 2 months after surgery. And when this figure was put up, and figures from other places were put up, those who are really into laparoscopic surgery say, not true, not true. Well, unfortunately, it is true. And given that we thought this big incision was very important, this led us to thinking there must be something else going on here because we've got rid of that big cut. So now each one of these each one of these sentences, in effect, the diagrams before, each represent a PhD pretty much or two. So, we've summarised, the research fellows who were involved with this were a little disappointed they only got a sentence in my presentation, but that's all they were worth really. No, they've done a lot of work. But so we asked ourselves, why aren't the results from laparoscopic or keyhole colorectal surgery a lot better than they are? You've got this much smaller wound, it does seem to be less painful, and yet patients, they may go home a day earlier, and in fact in our own work they don't go home any earlier at all. In a study from Denmark, they went home actually exactly the same time, but recovery appears to be the same. So we took a relatively, we weren't quite as disciplined about this as this looks, but scientists always are able to make things look quite logical in retrospect, but we took this approach. So the first thing we did was we developed a comprehensive measure so we could actually look at this properly. We started off with an unwieldy name of the identity consequence fatigue scoring system, as you would expect, designed by a psychologist, and so that was a measure of fatigue and its consequences and recovery. We sort of flipped it upside down with a few other tweaks, and we got what we call the surgical recovery score, which surgeons found much more interesting and exciting. We established then a relationship between inflammation, which we thought was coming from the inside of the abdomen, and fatigue. We were one of the first in the world to take on a Danish program of enhanced recovery after surgery and do our own things with it, and that's called ERAS, Enhanced Recovery After Surgery. And then we also made the observation, which surgeons have known about for a long time, which we thought possibly might be part of this, that after a major operation where you make this big cut in the tummy and you fiddle around in there and take about bits of bowel, there was at least 6 weeks when you can't really get back into the tummy because there's so much inflammation going on. All the scar tissue makes it almost impossible to get in. That resolves itself over about 6 weeks, and then you can get back in if you want to. So that might be a clue. Now, we did start to think more about the peritoneum. The peritoneum is an interesting thing. The peritoneum is the lining of the abdominal cavity. It's got a lot of convolutions, and those who are medical in the room will remember bits and pieces about this, but you won't remember it all. And in fact, even surgeons get confused about it. But it's got about the same area as the skin surface. It's about 1.8 metres squared. It's got a very active immunological system, which was something I didn't really think much about previously, and it has a very, very strong immunological response to injury. So the amount of these so-called cytokines or inflammatory mediators are 1,000 times the concentration inside the abdominal cavity after an operation than they are in the bloodstream, at least in the early phases. So this started to give us some thinking. And the other thing that was important was that the vagus nerve, I used to think it all went downwards. The vagus nerve, 80% of it actually sends messages upwards from the abdomen up to the brain. And believe it or not, it projects straight to parts of the brain that relate to sickness and relate to pain and fatigue. So a whole bunch of stuff starting to point to we might be having a bit of a clue here. So we developed what we call the two-wound hypothesis, and so we do an operation. You've obviously got to cut through the skin, so that's the top part of it, and that creates what we call a systemic response. You have, as you cut into the skin, the somatic nerves, the nerves of the abdomen pass through round to the spinal cord, up to the brain, and there's an inflammatory response and you feel pain, if you're not anaesthetised. And then, so that's why there's been very few anaesthetists admitted to the society, so just so you know. Then Ellen Mary from Auckland is the only one that I'm aware of. I'm sure there's others. And then there's also a local peritoneal response. So when you operate inside the abdomen, I just used to describe this to my patients as like letting an atom bomb off inside the abdomen. Until one of my colorectal surgeons says that may be your surgery, but I'm a bit more gentle. And that produces a local peritoneal response, as I described before, and that is carried through to the brain by the vagus and by a number of other things. We first of all started off by using dexamethasone, which is a steroid, which has found its own role in COVID, as some of you will be aware of. It's a very powerful anti-inflammatory drug, and we gave it to patients before surgery in a randomised controlled trial. And we demonstrated that when you gave this and dampened down generally inflammation in the body, but perhaps more specifically in the peritoneum, because we did have drains in, and we demonstrated that inflammatory response was decreased, you could see that these fatigue scores, or this recovery, this was fatigue, looking at that identity consequence fatigue score that I mentioned, you can see that it's lower out for at least a month or so. So dampening down inflammation, this was part of the clue. We then decided, and this is what people like to say is a complicated diagram I'm going to work my way through with you, and it's why I wanted this. This is the only reason I wanted the slides, actually. So with this two-wound hypothesis, we thought, can we block that message that's going from the abdominal cavity up to the brain? Now, there is an operation called a vagotomy where you cut the vagus nerve, but it's really one we've given up doing really in recent years because it was done for ulcers. And it was very effective for managing stomach ulcers and duodenal ulcers. And it's not really ethical to say, just while I'm taking your colon, I'll just quickly cut your vagus nerve. You know, you can do that. You can do that in a rat, and people have done it. But in a human, most people wouldn't sign up to that experiment. So we spent some more time thinking about it, and we thought this is the way we thought about things. So you've got your surgical trauma. It goes through the abdominal wall, up through the spinal cord, up into that brain stem, and up into parts of the brain where you interpret as pain. Now you can block that by using epidural. You can also block it using a number of other techniques in the abdominal wall, or you can use spinal, or you can, anyway, there's a variety of different ways you can do that. So that's relatively easy. There's a little bit of that message from the peritoneum goes up through the spinal cord, but most of it goes up through the vagus. Now we can partially block the vagus by running infusions of local anaesthetic into the peritoneal cavity. So we took a drug called ropivacaine. We gave people an epidural, and we gave them either ropivacaine into the abdomen or saline into the abdomen. And then we looked at the outcome. So we were looking at effectively a vagus block from the peritoneal cavity. And we did that for 3 days. You can only do it for 3 days because people are starting to itch about getting home after 3 or 4 days or 5 days. So there's only so much time you could do it. And of course, you always worry with having drains into the tubes of the belly, you might get an infection or something. So 3 days is what we've done. And this is looking at pain as a proxy, in this case, for recovery, but I'll show you recovery scores in a minute. This is looking at opioid scores, which are a pretty reliable way of looking at the pain, opioid use. And you can see in the group that had the intraperitoneal local anaesthetic that the amount of opioid used was about 1/3 less. And this was in people who already had an epidural, so that wound in the abdomen was blocked. So we're really only blocking the inside. So you can see that that inside had quite a significant effect. On day 3, we were taking the epidural. Day 2, we took the epidural out. So now we were getting the poor old intraperitoneal local anaesthetic trying to block everything, which was a bit unfair. So, and then obviously for the rest of the time. So if you just took the first 3 days, you can see there's quite a significant benefit. So in other words, it looks like the vagus nerve is somehow involved in this. Now some people, this was looking at fatigue or recovery, in this case using the surgical recovery score, so flipped upside down. And you can see the effect on patients was significantly different in the first few days. In fact, it went out to about a week where there was an improvement in recovery. And we also measured inflammatory markers, and they were decreased, which was a little unexpected, actually. Now, some people the few people, we didn't have 65,000 downloads. That's amazing. And I just think you should run a parallel import with your book and sell it here. I haven't seen it in Wood Calls yet. I'll be looking to buy it. But some people who thought about this said, well, maybe that intravenous local anaesthetic is leaking into the blood, and it's running around and acting somewhere else. We don't know where, but somewhere else, because some other people had been running very short-acting infusions of local anaesthetic via the bloodstream. 3 minutes to go, thank you. So what we did was we compared intraperitoneal local anaesthetic, and this study only finished last year, versus intravenous local anaesthetic. So in one group, we ran intravenous local anaesthetic for 3 days, and then we had a tube going to the abdomen. We just ran saline. And in the other group, we had intraperitoneal local anaesthetic run to the belly, and in the other trip was just, and the drip was just saline. Does that make sense? And you can see here, and I haven't shown you all the data here because I didn't want to bore you, but you can see here that the amount of opiate required for management of the pain in the group who had the intraperitoneal versus the intravenous, in other words, the abdominal block versus the circulation stuff, you can see that the amount of opioid was much less than a half. And this confirmed our theory, and I know some people might have some even more skeptical people might have some other thoughts, but let's just, I'm a simple surgeon, so just this, in my mind, confirms that this peritoneum is actually quite important. So this is the way I think about it now. I think the two-wound hypothesis is a reasonable hypothesis. I would argue that we're close to having proved it. We showed that in a randomized controlled trial, that intravenous dexamethasone dampens down inflammation. We then showed, we actually, because we did in laparoscopy, you're running these gases around, and we thought that these gases running around the tummy might desiccate the peritoneum. And we humidified those gases. That was a whole PhD, actually won a university vice chancellor's doctoral thesis award, but it was a negative study, very disappointing. We've shown that you can block that vagal transmission at least partially by intraperitoneal local anaesthetic. We have done a study looking at manipulating the way people think about about things, and that shows an improvement also in outcomes. And these are some other studies we've done or other things we've commented on that seem to make, they have varying differences. So all these are PhDs that have been done. So how do you think about laparoscopic surgery? Now, those of you, this is getting a little bit, you have to think this one through. If the operation traditionally required a very big wound, and what you're doing inside is really pretty minor, so a gallbladder is a really good example. You have to make a big cut, and the gallbladder is just a little thing. Then taking away the external wound makes sense, because there's not much to block inside, and that's the main contribution. If the external wound required is big, and the internal stuff you do is big, so, if the external wound is small-ish, and what you do inside is a big deal, then getting rid of the external wound doesn't make a lot of sense. So some of my colleagues are right into robotic pancreatic surgery. They know they're going to find me saying this is crazy. If the big external wound is big and the internal wound's big, so a colectomy for instance, then take away the external wound by all means. That's going to help a little bit, but you should probably also try to block that intraperitoneal vagus. And if it's a small external wound, small internal, like an appendicectomy, then depending on what you're trying to look at, it's actually easier to see inside the belly with a telescope, and and you may want it, there's cosmetic reasons potentially for it. So that's the way I think about whether you should be doing it laparoscopic or not. So in conclusion, laparoscopic surgery, some of my colleagues are trying to make the wounds even smaller. I think it's a waste of time. Future improvements are going to come from addressing that internal wound, and we've now got a nice product that we're developing that we're trying to work out the IP around that we think will help people with that. And this last term is already for the surgeons in the room, and there's none of you, I don't think, but the term minimal access, which is what which is where you're making small holes, was what I'd call laparoscopic surgery, is not necessarily minimally invasive, which is what everybody says it is. Thanks very much.